Hello, everyone, and welcome to The Funnel Effect.
It's great to be here.
Today, we are embarking on a journey into, well, the heart of emergency medicine. Literally. We're going to take a stack of data that is so big it's almost hard to wrap your head around, and we're going to funnel it all down into a single critical decision.
Yeah, a decision that doctors have to make when a life is truly on the line.
And you're right about the scale. We are looking at a study that didn't just, nudge the needle.
No, not at all. It grabbed the needle and completely redirected it. It's a perfect example of how medical intuition, even when it seems logical, can sometimes lead us astray.
And how only massive, rigorous data can bring us back to the truth.
That's it.
So let's get into it. Today we are examining the seminal paper titled Early Intravenous, Then Oral Metoprolol in 45,852 patients with acute myocardial infarction. Randomized placebo-controlled trial. This study was conducted by the COMET Collaborative Group. The lead authors were Dr. Zhengming Chen and Dr. Jingxiang Shi, along with colleagues from the Clinical Trial Service Unit at Oxford and Fuai Hospital in Beijing. And it was published in The Lancet in 2005.
And that is a truly landmark publication. I mean, just hearing that title, for a cardiologist, it sends a shiver down your spine because of the sheer weight of it.
I want to pause you right there on the numbers. The title says 45,852 patients.
45,000.
That is not a typo.
Yeah.
That is the population of a small city.
It's absolutely massive. I mean, to give you some context, most of the landmark trials that we talk about, the ones that change guidelines, they might have 4,000 or 5,000 participants.
Okay, so this is an order of magnitude bigger.
10 times that size. It was a logistical masterpiece. You have to imagine this involved 12,250 hospitals all across China. Think about the infrastructure needed just to standardize the protocols, to get the medication out, and then to collect accurate data from over 1,000 different emergency rooms. It's a testament to the power of that community collaborative group.
And the stakes really matched the scale, didn't they? We aren't testing a lifestyle drug here. We're talking about acute myocardial infarction, AMI.
Heart attacks. Plain and simple.
And specifically, that critical window of emergency treatment right after admission, the golden hour, or maybe the golden day.
That's right. I mean, when a patient comes in with an AMI, the clock is just ticking so loudly. The heart muscle is being starved of oxygen because an artery is blocked, cells are dying. The whole electrical system of the heart is destabilizing.
So the decisions you make in those first few hours.
They determine everything. They determine whether that patient walks out of the hospital or not. And the community trial was designed to answer this one burning question about how to manage that specific high-pressure window.
So let's set the stage. Take us back to the early 2000s, before this paper drops in 2005. What was the conventional wisdom? If I came into the ER with chest pain, what were the doctors thinking about beta blockers?
The prevailing mindset was aggressive. We already knew from way back in the 1980s that beta blockers were incredibly beneficial for long-term heart health.
Right. So after a heart attack, you take a pill every day.
Exactly. If you survive a heart attack and you take a beta blocker pill every day for the rest of your life, your survival chances go up significantly. So the logic, which is very seductive, was, well, if it works for the long term, surely starting it immediately is even better.
Time is muscle, as they say. If the drug protects the heart, get it in there as fast as you can.
Precisely. The idea was that by giving the beta blocker intravenously IV straight into the vein, the second the patient hits the door, you could sort of freeze the heart attack in its tracks.
And there were other studies that pointed in this direction.
There were. Previous trials, like the Miami trial or ISIS-1, had suggested benefits. They weren't, definitive, but they leaned positive. So the medical community was really pushing for this door-to-needle approach with beta blockers.
But there was nuance there, wasn't there? It wasn't quite a slam dunk.
There was significant nuance, yeah. Those older trials were much smaller, and they were done in a different era of medicine. This was before things like routine fibrinolytic therapy clotbusters and really potent antiplatelet therapy became standard of care. And frankly, the older trials largely involved fairly low-risk patients. So you had this tension, you had a theory that it should work, but you didn't have the definitive proof that it was safe for everyone, especially in the modern era.
And that sets up our core conflict perfectly. This deep dive is going to explore that very tension between the potential benefits, like preventing fatal arrhythmias, and the potential hazards, like crashing the system.
Hemodynamic instability.
Right. We're going to funnel this massive data set down into a single conclusion. So let's start with part one, the hypothesis and the protocol. Why beta blockers in the first place? I know they lower blood pressure, but what's the specific mechanism that made doctors think this would save a dying heart?
Okay, so it all comes down to a really fundamental concept in cardiology: supply and demand.
Oh, wait.
In a heart attack, you have a supply crisis. A coronary artery is blocked, so the supply of oxygenated blood to the heart muscle is cut off.
The engine is just starving of fuel.
That's it. But here's the problem. The body's reaction to this crisis is to panic. The sympathetic nervous system just floods the body with catecholamines,
Adrenaline.
adrenaline and noradrenaline, yeah. And this just whips the heart to beat faster and to squeeze harder.
So the heart is already starving and the body is screaming at it to run a marathon.
Precisely. It creates a massive demand for oxygen that simply cannot be met. And this mismatch, this huge gap between supply and demand, leads to ischemia, cell death, and electrical instability.
And beta blockers, they step in how?
Beta blockers, specifically metoprolol in this study, they act as a brake. They block the beta-1 adrenergic receptors on the heart. They essentially blunt that adrenaline surge.
They tell the heart to chill out.
Yes, exactly. They lower the heart rate, they lower the blood pressure, and they reduce the force of contraction. The hypothesis was simple. By reducing the workload and the oxygen demand of the heart immediately, we can limit the size of the damage, save the muscle, and prevent the heart from going into a fatal rhythm.
It sounds so logical. I mean,
What?
if the heart is stressed, let's calm it down immediately.
It is logical. It makes perfect physiological sense on paper. But as we see time and time again in medicine, what makes sense on a chalkboard doesn't always translate to survival in a complex, panicking biological system.
So let's look at how they tested this. The committed study design,
Right, so it was a 2x2 factorial design.
which you mentioned before. That means they were answering two questions at once.
Exactly. They randomized patients to get either clopidogrel, which is an antiplatelet, or a placebo. And at the same time, they randomized them to get metoprolol or placebo.
But for our deep dive today, we are funneling our focus entirely onto the metoprolol arm. We're setting the clopidogrel data aside for this conversation.
Correct. We are looking strictly at the beta blocker question.
We talked about the scale, that huge number, 45,852 patients. Why did they need that many? Was it just for bragging rights, or was there a statistical reason?
No, it's all about statistical power. They knew that mortality rates for heart attacks were already dropping because general care was improving. The placebo group event rate was actually lower than they historically expected, about 10% instead of the 14% they planned for.
Ah, so the baseline risk was lower.
Exactly. And when your baseline death rate is low, you need a massive sample size to reliably detect a small benefit, or, just as importantly, a small harm. If they had done this with only 5,000 patients, they might have missed the signal entirely.
Okay, that makes sense. And who are these patients? What kind of heart attacks were we talking about?
These were patients admitted within 24 hours of their symptoms starting, and the vast majority, 93%, had what we call ST segment elevation or bundle branch block on their EKG.
Which means major heart attacks.
These are the big ones, yes.
And there's a crucial note here about who was excluded, which is really important.
Yes. This is vital for applying the results today. Patients who were scheduled for primary PCI.
That's angioplasty, where they rush you to the cath lab and put a stent in.
Right. Those patients were generally excluded. So this study focuses largely on patients who were getting fibrinolytic therapy, the clot-busting drugs, or, in many cases, no reperfusion therapy at all.
So this represents a scenario where the artery isn't being mechanically opened right away. It's about medical management in that first crucial period.
Correct. Which, was the standard in many parts of China at the time, and frankly remains the reality for many patients globally who don't have immediate access to a cath lab.
Okay, let's talk about the intervention, the actual treatment regimen. Because when I read the protocol, it struck me as incredibly aggressive compared to how things are done now.
Oh, it was. It was designed to be a loading dose. The goal was to achieve rapid, total beta blockade as quickly as possible.
So walk us through it. A patient gets randomized to metoprolol. What happens next?
Okay, so they would receive up to 3 intravenous injections of 5 milligrams of metoprolol immediately.
Push right into the vein?
Pushed over a few minutes, yes. So that's a potential 15 milligrams straight into the vein in a very, very short window.
But they weren't just doing it blindly, right? There were safety checks.
Oh, absolutely. They had strict protocols. They monitored the patient's heart rate and blood pressure between each injection. So if the heart rate dropped below 50 beats per minute, or if the systolic blood pressure dropped below 90, they stopped. They would not give the next dose.
So they weren't being reckless, but they were being forceful.
They were. And it didn't stop there. Just 15 minutes after that last IV injection, they gave the patient a 50 milligram oral tablet.
Wow.
And then starting the next day, they gave 200 milligrams of controlled-release metoprolol every day for up to 4 weeks.
That is a seriously heavy front-loaded dose.
Yeah.
They really wanted to shut down that adrenaline response and shut it down now.
They did. They were betting the farm on the idea that rapid, aggressive blockade would save lives.
So we have the hypothesis, calm the heart, save the life. We have the protocol, this aggressive IV metoprolol regimen. We have 35,000 patients. Let's move to part 2, the primary outcomes. The surprise.
And this is where the story gets really, really complicated.
Okay, well, I'm going to cut right to the chase then. The big question. Did it save lives?
No.
Just
A flat no.
a flat no. When they looked at their primary endpoint, which was a composite of death, reinfarction, or cardiac arrest, the numbers were, for all intents and purposes, statistically identical.
Give us the data points. Okay. In the metoprolol group, there were 2,166 events. That's 9.4%. In the placebo group, there were 2,261 events. That's 9.9%. The p-value was >10.
Which, for our listeners, means not statistically significant. It's in the realm of random chance.
Correct. And if you look at death alone, it's even closer. 1,774 deaths in the metoprolol group versus 1,797 in the placebo group. That's 7.7% versus 7.8%. The survival curves on the graph are practically lying on top of each other.
So if you just read the abstract quickly, you might think, okay, the drug does nothing. It's basically saline.
But that would be a catastrophic misinterpretation of the data. The drug did a lot. It had massive physiological effects. But this is the funnel effect in action. What was happening was the drug was pulling the patient in 2 completely opposite directions at the very same time.
It's a tug of war.
It is the perfect medical tug of war, a classic example of competing risks. And understand why that overall death rate stayed flat, we have to dissect the data. We have to look at what the drug improved and what the drug, well, what it destroyed.
Okay, let's start with the good news then. Let's go to part 3, the benefit, the calming of the electrical storm.
So that initial hypothesis about reducing oxygen demand, it was correct. By slowing the heart down, metoprolol did prevent reinfarction.
Then reinfarction means having a second heart attack while you're still in the hospital for the first one.
Yes. The heart muscle is incredibly unstable in that period. If you can lower the demand, you can save the tissue that's on the brink. And the data showed an 18% proportional reduction in reinfarction.
18%, that's not trivial.
Not at all. In real numbers, that was 464 patients in the metoprolol group versus 568 in the placebo group. Has a real, tangible benefit. More than 100 people were spared a second heart attack.
And then there's the other big one, VF, ventricular fibrillation.
This is the killer arrhythmia. VF is when the heart stops beating and just starts quivering. It pumps no blood. It is, by definition, sudden cardiac death.
And metoprolol helped here too.
Significantly, there was a 17% proportional reduction in VF. So 581 patients had VF in the metoprolol group versus 698 in the placebo group.
Again, that's over 100 lives saved from this sudden electrical death.
If you do the math, if you look at it per 1,000 people treated, the drug prevents about 5 people from going into VF. In a vacuum, if you only looked at the rhythm strips, if that's all the data you had, you would say this drug is a miracle.
Right. It stops the heart from shaking itself to death.
Exactly.
And the timing of this benefit is also interesting, right? It wasn't all on day one.
That's a great point. These benefits preventing reinfarction and VF, they tended to emerge more gradually. The curves for those outcomes separate more widely after day 1. As the treatment continued, the protection accumulated.
Okay. So we have a drug that stops second heart attacks and stops sudden death. Why on earth didn't the overall survival improve? What's on the other side of the rope in this tug of war?
Part 4, the hazard, the pump failure.
Okay. We have to introduce the villain of this study's results, cardiogenic shock.
And it sounds like a clinical term, but it is a terrifying condition to witness.
Define it for us. What is cardiogenic shock?
Think of the heart purely as a mechanical pump. Cardiogenic shock is when that pump fails so profoundly that it physically cannot push enough blood to the organs to sustain life.
So blood pressure just collapses.
It plummets. The systolic might drop below 80, even 70. The patient becomes cold, clammy, their skin is mottled, they become confused, their kidneys shut down because there's no blood flow. It's a downward spiral of multi-organ failure.
And what did the Kevini trial show regarding shock?
The numbers are incredibly stark. There was a 30% proportional increase in cardiogenic shock in the metoprolol group.
30% increase. That's a massive safety signal.
It's huge. In absolute numbers, that was 1,141 cases of shock in the metoprolol group. That's 5.0% of them, versus only 885 in the placebo group, which was 3.9%.
So let's translate that back to our per 1,000 metric to compare it to the benefit.
Right. The drug caused an absolute excess of 11 people developing shock for every 1,000 people treated.
Okay. Now, the math of that flat mortality line suddenly makes perfect sense.
It clicks into place, doesn't it? Let's do the net calculation as they did in the paper. On one hand, you saved about 5 people from VF. That's electrical death.
Right.
But on the other hand, you caused shock in 11 people. That's mechanical death. And since cardiogenic shock is highly fatal, that excess of 11 cases of shock completely cancels out and even slightly outweighs the benefit you got from preventing VF and reinfarction.
We traded electrical death for mechanical death.
That is the perfect way to phrase it. We prevented the heart from beating too fast, but in doing so, for some patients, we stopped it from beating strong enough to live.
And the timing here, you said it was different from the benefits. The hazard was immediate.
Crucially different. Unlike the benefits which accumulated over days, the shock happened immediately. The vast majority of that excess shock was observed during days 0 and 1.
Which corresponds exactly to when they were pushing that aggressive IV loading dose.
Exactly. We took patients who were already hemodynamically fragile. I mean, you have to remember, they are in the middle of a massive heart attack, and we took away their primary support system. We took away their adrenaline at the most vulnerable moment.
This is a really important concept. Adrenaline as a support system. We usually think of adrenaline as the enemy in a heart attack.
It's a classic double-edged sword. Yes, absolutely. It increases oxygen demand, which is bad. But if your heart muscle is stunned and failing, if your stroke volume, the amount of blood pumped with each beat, is low, how does your body maintain blood pressure?
It has to beat faster.
It has to. Cardiac output equals stroke volume times heart rate. It's simple math. If your stroke volume crashes, your heart rate must go up to compensate. That tachycardia, that racing heart, it's a compensatory mechanism. It's a crutch that's keeping the patient standing.
And the IV metoprolol kicked the crutch away.
That's exactly what it did. We saw a fast heart rate and we thought, that's bad, let's fix the number. But by fixing the number, we crashed the entire system.
This has to lead us into part 5, risk stratification. Because surely this didn't happen to everyone. A healthy 40-year-old with a small heart attack probably handled the drug just fine.
You're absolutely right. The harm was not evenly distributed at all. And the study authors did a brilliant retrospective analysis. They created what they called a shock risk index. They categorized all 45,000 patients into low, medium, and high risk for developing shock.
Okay, so who are the high-risk patients? Paint a picture for us of the patient who got hurt the most by this strategy.
Imagine a patient who is elderly, let's say over 70 years old. They come in and their blood pressure is already on the soft side systolic, less than 120. Their heart rate is racing, it's over 110 beats per minute. And they have clear signs of heart failure on exam, specifically what we call Killip class 3.
And Killip class 3 means fluid in the lungs. You can hear crackles with a stethoscope.
Yes. Pulmonary edema. The pump is already failing to clear the blood coming back from the lungs. So you have an elderly patient, wet lungs, lowish blood pressure, and a racing heart.
Now, if you look at that patient through the eyes of a doctor in 2004 before commit, you see a heart rate of 115. You think, I need to slow that down. I need to save oxygen.
That was the instinct. But the data from this trial just screams, stop.
Yeah.
In this specific high-risk group, when they gave them metoprolol, there were 24.8 more deaths per 1,000 patients treated.
25 excess deaths per 1,000. That is a staggering number. That's clear iatrogenic harm.
It's a huge signal. And it confirms, without a doubt, that in these specific patients, that high heart rate was keeping them alive. Blocking it was fatal.
What about the low-risk patients, the stable ones, the ones who look like they should do well?
So in the low-risk patients, the ones who more closely resembled the participants in those older positive trials like Miami, there was actually a trend toward benefit overall. But, and this is the absolute key takeaway from the whole study,
Go on.
even in that low-risk group, on days 0 to 1, there was no net survival gain.
So even for the healthiest patients, the immediate IV dose didn't save any lives on that first critical day.
No. The benefit for them only appeared from day 2 onwards. So even in the best case scenario, the upfront risk of that IV loading dose completely canceled out any immediate benefit.
Okay, let's briefly touch on part 6, other clinical outcomes. Because it wasn't just this black and white outcome of full-blown shock or survival, was it?
No, not at all. There was a whole spectrum of harm. Even for the patients who didn't go into shock and die, many of them got sicker. There's a 12% increase in heart failure that required treatment.
So they needed more diuretics, more support. They were sicker in the hospital.
Right. Persistent hypotension, low blood pressure that wouldn't come up was twice as common in the metoprolol group, 6.0% versus 2.9%.
And what about the heart rate itself? Bradycardia.
Bradycardia, a dangerously slow heart rate, was more than double, 5.4% in the metoprolol group versus 2.2% in the placebo group.
Did they look at things like strokes or bleeding? Especially since they were also testing clopidogrel in the other arm of the trial.
They did track it, but for metoprolol specifically, there were no significant differences in strokes or bleeding complications. This was purely a hemodynamic story. It was a failure of the pump, not a failure of the clotting system.
So we have all the pieces of the puzzle. The drug prevents arrhythmias, but causes pump failure. The bad outweighs the good in unstable patients, and it cancels it out in stable ones during that first 24 hours. Let's move to part 7, synthesis and conclusion. How did this change the world? How does this change what a doctor does in the ER?
It was an immediate and massive pivot in practice. I mean, before commit, the push was give it early, give it IV, give it to everyone. After commit, that practice for the routine patient effectively stopped overnight.
It killed the routine use of 5E beta blockers in the ER for a heart attack.
It did. The guidelines were rewritten very quickly. The authors themselves concluded that it is prudent to wait.
Prudent, a very classic, understated medical way of saying, for God's sake, be careful.
Exactly. And the new mantra became stabilize first, block later.
Explain that approach. What does that mean in practice?
It means you admit the patient. You get the EKG. You give them aspirin. You start working on opening the blockage either with clot busters or by getting them to the cath lab. You wait, you watch them. You make sure their blood pressure is stable. You make sure their heart rate isn't a compensatory tachycardia. You make sure their lungs are dry.
And then, if they're stable on day 2 or day 3,
then you start the beta blocker. Because remember, the benefit for preventing reinfarction and VF remains. The drug is good. We just figured out we were giving it too fast and too early to the wrong people.
So it's not that the drug is poison, it's that the timing of the drug was poison.
That's a perfect summary. Once the patient is hemodynamically stable, say after day 1 or 2, that risk of cardiogenic shock disappears. The patient isn't relying on that massive adrenaline surge to stay alive anymore. So you can safely introduce the drug to get all those long-term protective benefits. That is the sweet spot.
And the route of administration matters too, doesn't it? Oral versus CV.
The study strongly suggests that avoiding that big IV loading dose is likely the key to safety. Starting with a low-dose oral medication once the patient is stable allows the body to acclimate. You don't just pull the rug out from under the cardiovascular system.
This study, with its 45,000 participants, it essentially just settled a decades-long debate. We don't need to run this trial again.
No. This is what we call a definitive trial. It's a mega trial. It proved quite painfully that more treatment faster isn't always better. By trying to prevent electrical death from VF, we inadvertently cause mechanical death from shock in vulnerable patients.
It's just a profound lesson in the delicate balance of physiology. You can't just pull one lever without affecting the entire machine.
And it really highlights the danger of treating a number instead of the patient. We saw a high heart rate on the monitor and wanted to lower it, but we didn't stop to ask why the heart rate was high.
Let's wrap this all up.
Okay, to summarize, the COMMIT trial showed that early aggressive AV metoprolol in acute MI reduces reinfarction and ventricular fibrillation. However, it also significantly increases the risk of cardiogenic shock. These effects cancel each other out, resulting in zero net survival benefit during the hospital stay.
A flat line that ended up teaching us everything.
Indeed.
And I want to leave our listeners with a final provocative thought. This study was about beta blockers and heart attacks, but the principle here, it applies everywhere in medicine.
It really does. It raises a fundamental question for all medical interventions we do. Are we treating the risk factor or are we treating the patient? Sometimes the body's compensatory mechanism, whether it's a fever or a cough or a fast heart rate, is there for a reason.
It's the body trying to survive.
Exactly. It's the body's attempt to maintain homeostasis. And if we block that mechanism blindly, just to make the numbers on the screen look normal, we can cause profound, even fatal harm.
We have to respect the wisdom of the body.
We absolutely do. Our job is to support it, not just to override it based on a single data point.
Thank you for helping us funnel this massive amount of data into such a clear and powerful lesson.
It was my pleasure. This is one of the most important studies to understand.
Thank you for watching The Funnel Effect.